So I want to present Dr. Cody Dunne, our webinar guest today. He is going to run us through oxygen and National Lifeguard. And over to you, Cody.
Awesome. Thanks so much, Kevin, and thank you so much to Lifesaving Society Ontario for having me. I'm excited to chat with everyone today and give you a little insight into kind of what's been going on in the world of oxygen therapy and lifeguarding across the world and where I think it may play a role in Canada in future years. At the end of the slides, I'll have an email address, so feel free if you want to send direct emails or questions after. That'll be on the last slide, and you can reach out to me at any time. So no financial disclosures to declare. However, I was a co-author on both the American Heart's resuscitation following drowning guidelines as well as ILCOR's updated treatment recommendations. So just be aware of that when we're discussing some of the guidelines. I thought I'd just do a quick slide about me because I am not from Ontario. And so hopefully to just get to know you guys a little bit more. So I joined the society in 2004 when I completed my medallion. So over 22 years now doing lifeguarding, life-saving, different activities. Went up to the ranks as most of us do, national lifeguard, swim instructor, head lifeguard, trainer, and then national trainer with the first group in 2017. From there, I kind of moved out of aquatics for my day-to-day job and went into medicine and completed med school at Memorial in Newfoundland, followed by my emergency medicine residency in Calgary. I was a member of the International Life-Saving Federation's medical committee from 2019 to 2026. And then currently, I'm an emergency medicine and transport medicine physician based out of Calgary, Alberta. I'm a PhD candidate, and my PhD studies all focused on pre-hospital resuscitation. So what people at the poolside, at the roadside, what our EMS colleagues are doing, and how we're intervening on sick patients is my area of interest. And then I'm the National Medical Advisor for Lifesaving Society Canada and have been for the past couple of years. So working with a lot of great people across the country to continue to improve our first aid and lifeguard training. And my most recent adventure is my little one who joined us about 9 weeks ago, and I'm forever going to put her in all my slideshows. So today I want to focus on three main objectives. First, we're going to review the American Heart Association's and Heart and Stroke Foundation's 2025 focused update on cardiac arrest following drowning guidelines. Second, we're going to describe what the lung injury that happens following drowning and what role oxygen therapy can actually play for that. And then lastly, I want to discuss some practical steps to normalize oxygen therapy into Canadian lifeguard training programs. A bunch of you sent in questions related to this. I'm hoping to address most of them throughout the slides, but if not, Kevin has all of the questions too, and so we'll try to get to any of them that I don't address directly, or you can connect with me offline and we can chat a little bit more. Let's start off with the motivation for this talk. So as some of you may be aware, last year, the American Heart Association, along with Heart and Stroke Foundation Canada, who are our overarching resuscitation councils and help inform guidelines for all first aid providers across North America, they completed a focused review entirely focused on cardiac arrest following drowning, where 7 different topics were addressed, one of which was the use of oxygen. And that the outcome of those recommendations is what you're seeing here on the slides here. That trained rescuers should provide oxygen to persons with cardiac arrest following drowning. And I want to highlight here the green box, and that represents the class of recommendation. And it can range from strong, moderate, or weak, or you could even can say something's harmful for people who are requiring resuscitation. And what we're seeing here is a class 1 or a strong recommendation that oxygen should be provided to a drowning person in cardiac arrest. Not maybe, not that it's harmful, should be provided. And to put that in perspective, I went through the most recent guidelines, and here are some other class 1 recommendations. That lay rescuers should provide chest compressions to adults with presumed cardiac arrest, and defibrillators should be applied to shockable rhythms. So that I think highlights the importance that the guideline creators were stating when they created these guidelines and made this recommendation is that this is on the same page as we should be doing CPR and we should be using AEDs. These are core treatments that first aiders, lifeguards, healthcare professionals would know about to instantly apply and not doubt their effectiveness. So, what's different when it comes to oxygen for lifeguards? Well, one of the differences comes in the blue boxes. Oh, sorry, the blue boxes here. These recommendations for CPR and defibrillation is based on non-randomized studies, meaning not clinical trials, but observational studies where we looked at what happened when they were used, and they showed an effectiveness. In contrast, when we look at the drowning recommendations, the guideline group reached a strong recommendation. However, there was only limited data, and it was mostly based on expert opinion, and that's because of the strong physiologic rationale for oxygen and drowning injury. So let's take a moment and understand how the guideline group actually got here. And I think any conversation about the role of oxygen use by lifeguards needs to start with an understanding of the injury that we as lifeguards and aquatic workers are uniquely trained to manage. How does drowning injure the lung and ultimately lead to respiratory arrest, cardiac dysfunction, eventually cardiac arrest and brain death? And I want to make sure we're all on the same page by first off defining the key principle that drowning injury leads to hypoxia. And so, what does that mean? Well, when our body doesn't have enough oxygen circulating to it, our organs begin to dysfunction. In other words, the hypoxia or the lack of oxygen ultimately causes all our tissues and our organs not to do their basic jobs because they're not getting the fuel that they need. So, how does the body become hypoxic during drowning? Well, it's because of the injury that occurs. So, first, we may inhale or aspirate water. Now, when we enter the water, we're struggling, we're trying not to inhale that water. We may hold our breath, that's our instinct. But the longer we're under the water, and often within about a minute for the average person in distress, the carbon dioxide is going to get so high in our blood that regardless if we want to hold our breath or not, our brain is going to force that breath and we're going to be forced to inhale. And that high respiratory drive is going to cause us to inhale that water since we're no longer able to breath hold. If we unexpectedly enter the water, or if our head is partially out, or we're bobbing, or eventually as we begin to get confused and have an altered level of consciousness, we're also going to swallow water. And after a critical amount of water hits our stomach, we're going to vomit. And just like when we inhaled the water, we're also going to inhale that vomit that's coming up past our airway, which is also going to enter the lungs. So what happens when that water, freshwater, seawater, ocean vomit hits our lungs? Well, it's directly going to injure the alveoli in our lungs. So those alveoli are those final branching points of our lungs. They're the smallest part. And they're the critical structure where oxygen comes in from the airway and gets transported into the blood. And for context, there are hundreds of millions of alveoli throughout both of our lungs. When liquid hits them, the first thing it does is disrupt the lining. And so all of a sudden, the special chemical that keeps these alveoli open gets washed away, the alveoli collapse, and now they're no longer able to transport blood in that area transport oxygen into our blood in that area. There's a secondary injury too. The longer water is in our airway, it also draws liquid out from our blood, known as our plasma. And that gives that frothy, foamy liquid that we see in some drowning patients that keeps coming up from the lungs. That's actually being drawn out from our blood ourselves, from the blood itself. And that can keep happening even after we've rescued the drowning person. So the water that we inhale may stop because we've rescued them, but that frothy fluid that keeps getting hauled out of our lungs, as long as that inflammatory reaction is happening, we can keep having hypoxia even after the person's out of the water. And lastly, you have to remember that you don't stop breathing right away when you're underwater. So even though you lose consciousness, the brain is still having that drive to breathe. It's trying to get oxygen in and get CO2 or carbon dioxide out. And so the brain is going to keep telling your lungs to breathe in underwater until it reaches that critical point. All of this is going to contribute to hypoxia, and all of it's going to cause lung injury. Now, I know lots of you guys don't look at chest x-rays every day, so I'll walk you through it. And on the left, you see a normal chest x-ray. So in the center here, you have the heart, which is somewhat opaque. And then on either side of the chest, you have the black air-filled lungs, where they're almost transparent. You can see through them and see these white lines going across, which are the ribs. In contrast, on the right is a chest x-ray of someone who has recovered from drowning, where now those black air-filled spaces are completely white. They're opaque, you can't see through them, and that's the water, frothy edema, vomit that is injuring your lungs and not allowing oxygen to get to where it needs to be in those alveoli. That lack of oxygen gives us hypoxia and our organs can't get any of anything that we're breathing in. So why do we care about hypoxia? Well, we have to remember that even though we're not taking in oxygen anymore, our heart is still pumping. Okay, so the blood is still reaching the alveoli, but because there's no oxygen molecules for it to haul in and get transported into the blood, the circulating blood never gets reoxygenated and it gets pumped back around to our organs, deoxygenated, starving them, not giving them the fuel that they need. And this is going to result in dysfunction. So the order of dysfunction is important though. So first, after about a minute of our brain receiving hypoxic blood, that's the short term, we're going to lose consciousness. So we're no longer going to be able to self-rescue or control our response. Next, we have to remember that our lungs are actually organs ourselves. So not only do they help bring in the oxygen that goes to our body, but they also steal a little bit for themselves to give them fuel. And within about 1 to 2 minutes after we lose consciousness, we're going to end up going into respiratory arrest, where the lungs are not getting fed enough and they're going to fail. So the person's no longer going to spontaneously breathe. Then, after about another minute or two, our heart will dysfunction. The contractions will get less frequent, our heart rate will drop, and they're going to be less effective. Each pump is going to send less blood forward. And physiologically, that's a decrease in our blood pressure. And this is going to happen until a critical point is reached and we reach cardiac arrest. Lastly, we come back to our brain because this is the organ that makes us who we are as a human. And following the lung injury and successively our body going into respiratory and cardiac arrest, the brain also dies. And now I'm sure in some first aid course or lifeguarding course, you've been taught that, after about 6 to 10 minutes, you're going to suffer from brain death that's irreversible. And while that's a bit of a simplification, especially in drowning, I want to actually highlight something that's arguably worse than that irreversible brain death. Because brain death doesn't actually just occur at minute 10. Your brain's alive and then your brain is dead and there's no coming back. Brain cell death happens along a spectrum. So from the moment our body becomes starved of oxygen, from the moment hypoxia sets in, brain cells begin to die, and we can't predict what order or at what rate these cells are going to die and affect our bodily function. So while we often think of resuscitation as black and white, saved, not saved, breathing, not breathing, survived, never survived, there's truly a much larger spectrum here. So when we intervene on someone and get a pulse back, their brain may still work, but not necessarily in the same way. The hypoxic period may have been long enough to injure few enough cells that sure, their heart and lungs will breathe, but too many cells that they'll never be the same person again. They may not remember their family, they may not be able to walk, they may not be able to eat by themselves. In other words, they survived, but their neurological function is sorry, their function and directly their quality of life is greatly impaired. So what I want to stress here is that drowning injury isn't just happening when someone is not breathing, but it's happening along this spectrum, and any prolonged period of hypoxia can ultimately cause a poor outcome for someone. Now let's contrast that with the other major cause of cardiac arrest that we'll see. Let's imagine someone's exercising in the gym next to your pool or playing sports on a beach that you're guarding. And whether due to a massive heart attack, a predisposing genetic condition, they develop a shockable arrhythmia. In contrast to our drowning person, which who undergoes a progressive state of slow hypoxia, slow cell death over 5 to 10 minutes, the person suffering the heart attack, they lose consciousness, stop breathing, and become pulseless instantaneously once the arrhythmia begins. And that contrasts to our drowning injury with the prolonged buildup. And so your team gets there, starts CPR, and applies the AED as you've been trained, and you treat what's causing the cardiac arrest, the shockable arrhythmia. You shock it or defibrillate it, that person gets a pulse back, starts breathing again, and you prevent that prolonged period of brain cell death. This much shorter window of injury is why shockable rhythms or cardiac causes of cardiac arrest are known to do better than non-shockable causes, like a lack of oxygen that we see in drowning. In this case, in the shockable rhythm, there's a clear cause of why their brain isn't getting enough oxygen. The process can start quickly, and we can correct it entirely quickly with the defibrillator. It's also why studying this type of cardiac arrest, so shockable cardiac arrest, is much easier because shockable rhythms are much more common. We know there's tens of thousands of these in Canada every year versus, you know, a couple thousand of significant drownings every year. You also have a straightforward pathway. The person's breathing or not. You shock them or you didn't. You can compare the outcome when they have return of spontaneous circulation or not. They survived or not. This binary process here is much simpler to study than the complex nature of drowning. And so that's one of the reasons that we're seeing more limited evidence in this field. So what about our drowning person? Well, we know that hypoxia is impacting our organs along the entire spectrum of injury from the moment drowning occurs. And so, why is it harder to study and why is the evidence harder to develop? Well, for example, there's a few different ways there's a few different places where drowning can intervene. For example, did you give oxygen here, where the conscious person has an injured lung but is alert, breathing on their own, just working hard to breathe, and their oxygen's a little low? Or did you give the oxygen here, after the person loses consciousness and is having difficulty keeping their airway open, but continues to spontaneously breathe on their own? Or what about when the person has stopped breathing? And remember now that for us at the poolside, CPR is initiated when someone stops breathing. So we won't actually recognize the difference of these different stages within the box here. We'd be applying oxygen along with CPR, but where they are on the spectrum is unknown. However, where we're intervening absolutely matters. For example, if you give oxygen and you get someone back who is not breathing but still had a pulse, their survival rate is still about 60 to 70% if their pulse truly never ever did stop. Their heart never completely dysfunctioned. But if you get someone back after their heart has already stopped, their survival rate drops from 70% down to 10%. So the earlier we intervene here still, even though this big black box is all, non-breathing, we're starting CPR, where that person truly is in that spectrum is going to matter their outcome, is going to affect their outcome. And where we intervene is absolutely going to result in a different outcome for them. In fact, that's the hope with oxygen therapy. Um, is that unlike AED and where we only apply an AED after someone has gone into cardiac arrest, they have a shockable rhythm, and we treat it. The hope with oxygen is that if we intervene on them earlier, we can actually stop that person from ever reaching cardiac arrest, from ever having those poor outcome numbers by giving them the oxygen when they're conscious and working to breathe, when they're unconscious, or when they're only in respiratory arrest. The early oxygenation can actually prevent them from ever getting into the most serious outcome, which is cardiac arrest. But you can see how this becomes more difficult to study because we're just talking about where did we intervene the oxygen, let alone if you consider that there's different types of oxygen you can give, and there's also different ways that oxygen can be delivered. It becomes a more complex intervention to study, but physiologically, it makes sense to intervene with it. Okay, so bear with me now for the only slide in this PowerPoint that has math on it. So someone out there is definitely thinking you've been taught that in your CPR course, using our exhaled air, the air that we breathe in and breathe out, is satisfactory for CPR and ventilations. And the logic is often because 21% or the room air has about 21% of oxygen that our body breathes in to use for ourselves. The remainder of room air is useless gases, nitrogen, carbon dioxide, nothing. It goes into our lungs and it goes out of our lungs. Our body's unable to use it. And when we breathe in that 21% oxygen, our lungs only extract about a quarter of it. So the air we breathe out has about 16% oxygen in it. And since that 16% oxygen has more than enough oxygen in it than we need to reach the alveoli and transport into the blood for the person that we're doing CPR on, we're able to continue oxygenating them in CPR with our exhaled air without any additional tools or supplemental oxygen. So why does this fall apart in drowning? Well, remember that principle is based on normal lungs. So when someone goes into cardiac arrest from a heart attack and a shockable rhythm, the single biggest cause of cardiac arrest, these people still have normal lungs. They're not hypoxic because they don't have any lung injury. Their heart just stopped in a second at the same time that their lungs did, and it hasn't had time to injure the lungs yet. So they still have hundreds and millions of working alveoli that are able to extract the oxygen from the air that you breathe into them. They don't care that 80 to 85% of the air you're breathing in is useless gases because there's so many alveoli there that are able to do that job and still extract anything that you blow into their lungs oxygen wise. But that's in contrast to our drowning injured victims. Remember that all that inhaled water and frothy foam collapsed hundreds of millions of our alveoli already. There's not that many of them working. So when we provide air that's only 16% oxygen, but most of our alveoli transporters aren't working, we can't even be sure that the few oxygen molecules that we're blowing in, that we're ventilating the patient with from our lungs are actually reaching the working alveoli. Maybe it's all the useless gases that are reaching the few working alveoli that are in there. What we want to do, and what we do when we apply oxygen is we crank up that percentage so that the air blowing into the person is close to 100% oxygen as possible. We've removed all the useless gases that are there. And so we know that every single alveoli that's still left working is going to get an oxygen molecule to absorb as opposed to something that's not going to help us. By doing this, we're uh, we're going to treat the hypoxia as best we can because we're maximizing any oxygen delivery to the patient. Whereas if we just use expired air, we don't really know what molecules, what gases are getting to the alveoli, and we might not actually even been treating the hypoxia that's causing the cardiac collapse. So let's imagine this in a different way. Think back to the last time that you had a chest infection, a bad flu, a pneumonia. In reality, that only affects a very small portion of your lungs. Now, imagine you were to run up a set of stairs quickly or run up and down the stairs a couple times, simulating your body increasing stress. And now picture that we took the 21% oxygen that's in the air and dropped it down to only 16%. You have less oxygen to breathe in, your body's requiring more oxygen, and a portion of your lung from that flu or that pneumonia isn't even effective in transporting oxygen in. Think about how bad that would make you feel. And now picture having lungs like the person on this slide, and we decrease the amount of oxygen in the room. That person is going to struggle so much more. This is like treating the drowning lung injury with simple exhaled air. We're not effectively treating the problem, and ultimately, we're not treating the cause of the cardiac arrest. So, hopefully, that gives you an understanding of why oxygen is critical in the management of a drowning patient. And in the case of cardiac arrest, how the guideline group reached a strong recommendation for oxygen therapy, even in the absence of strong clinical trials. But now we should ask ourselves, well, why us? Why lifeguards? And I think there's a few ways to answer this. First, we're uniquely poised and are experts at managing the drowning patient. Treating drowning is our core skill. And while nationally we've done an excellent job at creating experts in water rescue, first aid, and CPR, To date, we've not really addressed in a consistent, uniform national manner on drowning's core treatment, which is oxygen. We need to be able to manage this whole injury from start to finish as the experts. Second, time matters. Now, sure, in some centers, large cities, EMS is going to be there within minutes from being called for someone in cardiac or respiratory arrest. But I work in this world every day, and that's not the reality for all of Canadians. Our rural regions, who are already at greater risk of fatal and non-fatal drownings, also have limited EMS resources, and we see delays in receiving this advanced care like oxygen because paramedics are not able to get there quick enough. And this will further increase the risk of serious injury or death just by disparities in care from where people live. But these delays are not just rural anymore. In the emergency departments, in the pre-hospital environment, we're seeing a strained system. We're seeing increased EMS demands. We're seeing boarding in the emergency departments and delays to care across all communities, whether you live in an urban center or a rural center. And even for serious calls like EMS, it's a scary time, but we're seeing delays so that you cannot reliably across the country in many areas expect immediate response by paramedics and by EMS because of the strain on the system. And that means as lifeguards, you actually may be managing this critically unwell patient for longer than you anticipate. And as you can see, there's multiple points at which we can apply oxygen here. By intervening earlier, we hopefully stop the progression of the drowning person's hypoxia so that they don't progress to the next stage. Someone who's conscious in respiratory distress may have their breathing eased and not lose consciousness if we treat them with oxygen. Similarly, those in respiratory arrest may not convert to cardiac arrest and that massive increase of brain death or poor quality of life if we treat them early. So by getting oxygen before paramedics even arrive or before EMS even arrives, we may stop that progression to greater injury. And the AHA guidelines recognize lifeguards' roles. So while in prior versions of the guidelines, not only there's no clear recommendations for oxygen in drowning injuries, but the guidelines were either targeted towards healthcare professionals, physicians, paramedics, nurses, or otherwise lay rescuers. When we design these guidelines, we specifically recognize the role that lifeguards play and that certain other professions play as an intermediate step, as trained rescuers with unique skills that can help manage critically ill patients, in our case, drowning, in a unique way. That we have a unique space in this chain of survival, and that needs to be recognized. So, how do we apply this in real life? Well, one option is completion of an advanced airway management course or an oxygen administration course. Certainly in Ontario and in select other areas across the provinces, there are some version of that one way or the other. Well, that's an excellent course and an excellent educational tool. I actually argue it's more than what's needed. It goes above and beyond what our general lifeguards need. If we're going to find a way as a national organization to make this life-saving treatment more accessible and feasible for all affiliates to implement, lifeguards to use, and most importantly, aquatic patients to be able to be treated with, we need to minimize costs, minimize equipment needs, and minimize training requirements. We need to find a simple core set of oxygen therapy skills that can be easily integrated into our lifeguarding programs across the country. And let's consider our patients and where the options are that lifeguards could actually intervene on. So starting at the right side of the screen, we have our sickest patients. This is where it makes the most sense to intervene with oxygen therapy. And then earlier on, we have both our conscious and unconscious people who are in respiratory distress and working to breathe. So how can we intervene with oxygen on these people? So although there's a couple different ways you could play this or work this out, I'm going to give you a simple proposal. For all drowning patients who are not breathing, meaning they are in respiratory or cardiac arrest, we don't know which, but they're not breathing, so we're going to initiate CPR. We continue to use our pocket mask to give ventilations as we normally would mouth to mask, but we attach an oxygen inlet and run it at its max setting. This will give all patients over 60 to 75% of inspired oxygen compared to that 16% we would be giving if we were just using our expired air. Taking it another step forward for the pre-arrest patients, so those who are unconscious with breathing distress or conscious with breathing distress after a drowning event, we can apply a simple face mask connected to oxygen tubing and set it initially at 10 liters per minute. These early interventions are as important, as we mentioned, to stop the progression into worsening situations and worsening status. Remember, if a drowning person goes into cardiac arrest, about 10% survival. If we can stop that, so if we treat them with a pocket mask while they're only in respiratory arrest, about 70% of those will survive. But if we treat the patient before they stop breathing at all, so the unconscious person with breathing distress or the conscious person with breathing distress, less than 10% of those patients actually end up dying. So the earlier the intervention and stopping them from getting worse can truly save lives here. And this just represents a simple strategy. It's a set it and forget it approach so that we're not greatly disrupting our lifeguard training, but able to safely implement these types of interventions for our patients who need them. We don't need to become experts in all uses and manners of oxygen delivery. Some of you might ask about pulse oximetry. Certainly in a medical setting, we use it all the time, and it's an important tool. It's less clear in our setting, though, at poolside and waterside. Portable monitors in general aren't as reliable as the ones we use in hospital, and our patients are wet, cold, the blood vessels in their hands and their feet are collapsed because the body's trying to perfuse or keep all the oxygenated blood centrally and not let it be wasted in the limbs. And these devices measure peripheral blood oxygen saturations. They can be unreliable in our patients who are cold, wet, peripherally shut down. Some people worry about hyperoxia. So the other fear is that you might give too much oxygen. And that's the opposite of, our classic problem in drowning. And to be honest, it's not something we really need to worry about in our drowning population. Our individuals are treating our post-drowning patients are uniformly hypoxic, low oxygen levels due to their lung injury. And even if you temporarily apply too much oxygen to someone, it's far better than any prolonged hypoxic state. We can tailor oxygen saturations once paramedics arrive with a more reliable device and the patient's warmed and dried. And resuscitation councils like the American Heart Association and the Heart and Stroke Foundation already recognize this. Anyone in cardiac arrest gets 100% oxygen therapy until we're able to adequately titrate with a reliable monitor. So the worry here is that, or what I would argue is that you actually don't necessarily need pulse oximetry to implement oxygen therapy at a poolside for our drowning patients. And I want to also highlight that I have not discussed or recommended the use of any advanced airway equipment. Most people, when they think oxygen administration, they think the need for advanced tools, like the bag valve mask, like advanced airways, like a nasal airway or an oral airway, or supraglottic devices, which are on the right of the screen. I am clearly saying that we do not and probably should not be focusing on introducing these to our lifeguard programs, and we certainly don't need these devices to successfully apply oxygen in the ways that I've discussed with a pocket mask and a simple mask. Let's look at the data here. When we looked at bag valve mask ventilations, so there was a study done in among Australian lifeguards that compared effectiveness of different interventions when lifeguards used bag valve masks versus mouth to mask. And I'll remind you that our Australian surf colleagues are some of the top lifeguards in the world. Well, they found that the bag valve mask gave less effective ventilations by about 40% compared to mouth to mask. There was longer chest compression pauses, about 4 seconds longer, which we know is a measure of poor CPR quality, the longer your pauses. And the bag valve mask actually gives smaller ventilation volumes, probably because more air was escaping than mouth to mask. So in this study, bag valve mask clearly underperformed mouth to mask in our lifeguard population. Similarly, when they looked at the ability to give effective ventilations with bag valve masks, they trained 260 laypersons. This is a separate study, I should be clear, and that about half of them got retrained halfway through. When they did their initial testing, after they immediately got trained and did a testing right after, only about a quarter of people using bag valve mask ventilations were doing it right anyways. In the retesting, 9 months later, only 10% of both groups were doing the bag valve mask successfully. This shows how hard of a skill this is to do. And that's not to talk about more advanced airways like supraglottic devices and endotracheal intubations. I'm not going to spend a lot of time here because this is a bit above where most of our lifeguards would be focused anyways. But the point being is that what we've shown time and time again is that more advanced airways, if you're not well practiced, actually have worse outcomes than the simpler strategies. And in all areas of medicine, we love new equipment, whether that's pre-hospital, whether that's lifeguarding, whether that's in an emergency department. We think of having these extra tools, they make us better because we're able to intervene in new and novel ways or make or model like advanced providers are able to. In my job in the emergency department, I see this all the time when new tricks or toys or tools are introduced, and we think it's going to change the way we practice medicine. And then the evidence actually comes up and it shows that we're probably not as good at it as we think we are. And the same thing applies here. We know that airway interventions take time to master, and they're incredibly difficult to master. And keep that skill up if you're not doing it day to day. The vast majority of Canadian lifeguards will never have the resuscitation experience to achieve this. In fact, most physicians who work in acute care don't even get great at some of these interventions, no matter how much mannequin practice they have. To lean into the paramedic data, who is probably our most alike colleagues, it's shown that the most advanced airway intervention that they do, so when they intubate someone, they put a breathing tube in them, it actually worsens people's outcome in cardiac arrest if they're not doing the technique regularly. And I'm not talking about practicing on mannequins, I'm talking about performing it on actual humans. That outcomes in cardiac arrest worsen if they use this more advanced technique, even though it's theoretically better. If you're not quick and adept at it because you use it all the time, it can actually delay care and other important treatments. So the analogy here to lifeguards and airway interventions like BVM and intraoral airways is clear. The timing, cost, and training for these advanced airway devices does not equate to improved outcomes that we know and that we've seen. And we shouldn't bog down our learners with this additional content when we instead could be focusing on our core treatments. And the American Heart Association and Heart and Stroke Foundation Canada support this as well and have not made a strong recommendation for any of these airway interventions, unlike oxygen therapy. So what now? This doesn't, just because we have this strong recommendation, now where do we go in Canada, or where do we start going at our poolside? What can we start doing to help making our treatments better for our drowning patients? What's important for lifeguards is not all the advanced airway tools. It's to remember that hypoxia is what kills our drowning patients. The lack of oxygen is what kills patients through these horrible lung injuries. The treatment for this lung injury is oxygen to prevent the hypoxia from worsening, to prevent them from going into cardiac arrest and dysfunction of our heart, lungs, and brain. The more we can apply oxygen above room air or exhaled air, the better we'll be able to overcome that horrible lung injury and make sure that the only gas that reaches our working alveoli is oxygen so that we can help save our drowning patient. We need to keep our strategy simple from a national standpoint. Some people will want advanced training in oxygen management and oxygen administration. These people should be encouraged, right? These are the early adapters. These are the people that change makers. But to keep it a manageable strategy for our general lifeguards, we need a simple checklist on-off strategy. I've provided two possible options here, one for cardiac arrest and one for a drowning person, conscious or unconscious, who hasn't stopped breathing yet. A set it and forget it approach until EMS arrives is straightforward and has potential to save lives. And now some of you are thinking, well, I don't have oxygen. And that's okay. There are lots of facilities out there that don't have oxygen available and may not have the resources now or in the near future to start applying oxygen or to implement oxygen. And that's okay. We're all going to be at different stages. But that doesn't mean we can't start training our lifeguards. It may seem like a lifetime ago for some of you, but I remember in the 2010 American Heart Update when AED was introduced as part of the CPR algorithm. Before then, you had to have medical oversight to use a defibrillator, meaning a physician had to sign off on your training, and you only had defibrillation if you did an additional course beyond CPR. This was a huge change. Besides facilities having to purchase AEDs, we all had to learn how to use them, and trainers were far more expensive and less plentiful than they are now. My first couple of courses learning defibrillation was literally with a piece of paper printed out with a picture of an AED and then two plastic pads that were tied onto the paper with a string. And when we did our simulations, the instructor read off the AED prompts from a sheet of paper. Was that the best way to be trained? Absolutely not. But did it begin to teach me the mechanics of using an AED? For sure. Did it begin to ingrain in my head, even if I may not have an AED available when I do CPR right now, I need to think about sending someone to try to find one, and I should always consider it a part of the package when someone stops breathing. 100%. 17 years later, and this is ingrained into every single person's head who completes one of our lifeguarding or one of our first aid courses, that AED is just as important as compressions. Well, oxygen is the AED of the 2025 guidelines. It is a new concept to many of us. We're worried it's too advanced for the average person. We're worried about the cost for our facilities. That's more of the reason why we need to begin to integrate this into our lifeguard programs. For the facilities that don't have the equipment, or even for those that do but don't want to waste their real resources, start simple. Get some tubing, a spare pocket mask, a simple face mask which costs a few dollars. To simulate the oxygen cylinder, attach it to an old cleaning spray container, an expired cylinder of something else. In the simulations that you're doing with your national lifeguards, candidates, or employees, have them use that in sims. Get them to talk through how they would turn on the tank, what they would set it to in terms of oxygen flow. Get them to put the mask on the mannequin or connect the oxygen inlet tubing to the pocket mask when they're doing CPR. Get them to list any safety concerns. Sure, if the candidates eventually work somewhere with an actual oxygen container, they will get onboarded to that when the time comes. Oxygen therapy is not the same regulation that other interventions like CPR and first aid do. There's not a requirement to have an oxygen administration course done in order to do that, in order to use it. It's up to the employer to find how they're going to make sure their employees are safe to use it. What I'm talking about from a national standpoint is how do we just start getting our lifeguards to think about it? The simulation may sound silly, but this is how AED training started 17 years ago. So that every drowning, every lifeguard in Canada thinks about oxygen and has a standard way to apply it every single time, is what we should be thinking. With time, this will normalize oxygen as the immediate treatment lifeguards think about for drowning and not an afterthought because, oh, well, we don't have it here. Slow, small steps can make monumental changes over the long term. From a national perspective, the medical committee is certainly working with the national organization to find how can we integrate oxygen more clearly into our lifeguard programs so that it becomes a routine intervention, simulated or not, but also recognize that we don't want to burden those facilities who don't have access to it. We just want to normalize lifeguards thinking about it so it becomes secondhand or first nature. The direction is clear where we need to head and what we need to do to help our drowning patients. The recommendation is clear and strong. Now we just need to start making slow, steady steps forward to normalize what is new.